See people joining. Just give it a little bit longer just for people who are running a little bit behind. Mm. Go ahead and get started. Well, welcome and thank you everyone for attending NAPSA's Research to Practice webinar on health equity in practice with our guest, Iggy Chang. I'm Esther Thorpe, the Administrative Project Coordinator with NAPSA, and I'll be moderating today's webinar. For those of you who are not aware, NAPSA, or the National Adult Protective Services Association, is a nonprofit membership organization that exists to provide training, advocacy, and networking opportunities for APS workers, allied professionals, victims of abuse, and anyone interested in preventing and raising awareness of elder and adult abuse. The webinar today has been organized by NAPSA's Research to Practice Interest Group, which is often referred to as R2P. So R2P is a network of researchers and practitioners across the country who all share an interest in advancing the field of APS and protective services. If you are interested in learning more about the quarterly webinars, the work that's being done with ADDI, which stands for APS Administrative Data Initiative, or you'd love to have a space to connect with researchers and practitioners, there is a R2P listserv that we encourage you to join. You can visit our website to learn more and get instructions on how to join the group. And I will also drop the link in the chat shortly. So before we get started, if you have any questions during the presentation, please go ahead and not go ahead right now, but during the presentation, please drop it in the Q&A box. And after the webinar, we'll have about 15 minutes or so to answer any questions. And if anyone has any comments or feedback, there will also be time for that as well. So just so everyone is aware as well, today's presentation is being recorded and the recording will be on the NAPSA website. So I will go ahead and I'll pass it to Iggy and have her introduce herself and begin.
Great. Thank you so much, Esther, and good morning or good afternoon, everyone. My name is Iggy Chen. I am Assistant Professor of Gerontology Medicine at Weill Cornell Medical College, and it is my absolute pleasure to return to present to this wonderful audience for the second time. I remember presenting here in this platform a couple of years back, sharing my research on the increasing prevalence of elder mistreatment during COVID. And after the webinar, I really received so many encouraging and helpful comments from practitioners and research colleagues. And it really speaks to the very fact of the importance of really collaborating across board, from researchers to practitioners, to really address these very challenging problems and to better protect vulnerable older adults in our communities. So I wanted to today actually anchor my talk surrounding the ideas of health equity, using a social and structural determinants lens to address elder mistreatment. I have no financial conflicts of interest to disclose, although I would like to acknowledge my funders from National Institutes of Health and National Institute on Aging. So by way of introduction, I am a public health researcher. That's my background. I was training social and behavioral sciences, and I have been invested in improving health equity in aging. My journey in elder mistreatment research actually first started while our research team was conducting health needs assessment in Asian American communities. And the issue of elder mistreatment really emerged organically through the hundreds of in-person interviews that I've conducted with Chinese older immigrants in Chicago. A lot of them were voicing the challenges and barriers of not just cultural and linguistic barriers, but also challenges in terms of experiencing the neglect and exploitation and mistreatment from family members as well as loved ones around them. So it was really during those early research experience that made me very aware and also interested in thinking about and dissecting the role of culture in elder abuse experience, help-seeking behavior, and also the ways in which our health systems are responding and addressing elder mistreatment. So this line of research, which really naturally progressed into my desire to better understand social and structural determinants of elder mistreatment, which has been the cornerstone of my research for the last decade. So this, of course, naturally begs the question, why do we study social determinants of health and elder mistreatment? And I'm not sure if I need to preach to the choir, because I think that's something that we all experience and in our day-to-day professional lives and practice, etc. But I think in general, in terms of research is concerned, I think we will all agree that the field has made tremendous progress in the last decades in understanding the individual and relational risk factors for elder mistreatment. So for instance, we do know that cognitive impairment is a pronounced risk factor for older adults experiencing elder mistreatment. We also know that the lack of social support is a big red flag, for instance, at the relational level. But what really interests me the most to think about and to address is that what is it about our society in general that still makes elder abuse such a prevalent and persistent and potentially intractable problem? So to answer this question is really my research program wants to identify the structural levels that lead to elder mistreatment, and therefore thinking about it as a structural question will naturally, hopefully lead to structural solutions. Maybe it's at the societal level or at the community level. And surprisingly, when I started embarking this line of research more than a decade ago, following the social ecological model that you see on the slide, really thinking about the different levels of risk factors and potential corresponding interventions for mistreatment, we have actually very little empirical evidence on some of the structural level risk factors. So that really inspired my research to improve understanding of these structural drivers that may help us better screen and prevent and intervene mistreatment in our healthcare system. So there are many ways to define social determinant of health. And the way that I think about social determinant of health perhaps is more in the simplistic terms, and that is corresponding still with WHO and CDC's definition, is really thinking about these wide-ranging non-medical factors that ultimately influence health. So in other ways, in other terms, is really thinking about the ways in which individual, where they're born, where they live and work, and play and worship and socialize and age, that ultimately all affect health. So in the chart that you see here, there are really many domains that we can think about: economic stability, food security or insecurity, etc. And altogether, based on existing research, we know that social determinants of health actually account for between 30 to 55% of health outcomes on a population level. So today I wanted to bring this in and center my talk around a key social determinant of my ongoing research program in the elder abuse space. And that really pertains to thinking about the role of discrimination, specifically societal-based discrimination. So that brings me to the role of ageism. And I first started exploring this, one of the most prevailing form of social injustice that I really spent a lot of time thinking about. And again, I don't know if I have to present my next slide in detail to this group, given that this is a group of experts, practitioners and researchers who work so closely with older persons, but ageism has been the cornerstone of my work. So I think it is important for us to think about ageism in several different terms in research. And here we define ageism as the systemic stereotype, prejudice, or discrimination against people because of their age. So let me break it down for you in terms of the different domains and concepts of ageism that we typically think about. So for instance, one way is obviously thinking about age discrimination, and this really refers to the behavioral and action toward older persons and the detrimental treatment of older persons. There are the other layer thinking about negative age stereotypes. And these are really all culturally based, thinking that aging is relating to negative connotations and all the very detrimental ideas about and stereotypical beliefs, which are not based on facts about older people in general. And this third layer of ageism, I think, has also equally detrimental impact and harm of our older person's health, is thinking about the negative self-perceptions of aging. In other words, you may hear this term in other parallel work that you do, is really the internalized age beliefs and older persons. And this is something based on research that we know that, individuals or kids as young as 3 or 4 years old can automatically already associate older person's image as something that's less desirable. And we can talk about this for another webinar, but it really has a lot to do with the culture and the popular imageries around us that we tend to absorb these negative self-perceptions of aging since young age and throughout the lifespan. So these are typically some of the concepts and terms that ageism researchers have spent a lot of time thinking about and how they're linking to the downstream adverse health consequences. However, ageism so far, the research so far has also mostly focused on the impact of ageism on these individual levels without much consideration, again, thinking about how ageism may operate on the structural levels. So to this end, and our research team a couple of years ago conducted the first ever really a global review of ageism on the health consequences of ageism, which then ultimately informed the global campaign of ageism and the report that's led by WHO, which I serve as one of the scientific contributors. And in this line of work, we were able to really call out structural ageism by giving it a definition. And this really refers to the explicit or implicit policies, practices, and procedures of social institutions that continue to reinforce these biases toward older persons on the societal level. And because of the insidious and internalized forms of ageism, we also wanted to make sure that we are capturing other forms of structural ageism, which will be these age-based actions of individuals who are in the position of making decisions. So these are the individuals who are part of these social institutions that they may very much refer to healthcare providers in a hospital, in other important areas of our social institutions. So in this systematic review, some of the things that we found is that is really the wide-reaching adverse health consequences of ageism. And this is really a 3-year project where we were able to sift through thousands of research studies. And in the end, we located over around 422 studies, and over 7 million participants were included in this review. We found the adverse impact of ageism, as you see in the world map here, in over 45 countries and also over time. So it really has no boundary, or in other words, ageism does not discriminate, right? So it's really reaching across the boundaries of geography and time. So let me give you some more concrete examples to really anchor our thinking about ageism. So for instance, we do know the adverse impact of racism, which is, it really makes people sick. That's something that, coming out from COVID, from pandemic, from contemporary, a lot of the social events that we've gone through, racism is really gaining a lot of traction, and rightfully so. But we wanted to think about, how does ageism compare to the impact of racism? So for instance, it turns out that ageism may be worse, because in this prior systematic review on racism that our research colleagues, they found over 64%, the yellow chart you see on the right, on the left, over 64% of the studies have found a negative impact on racism. We used the exact same identical methodologies, and we found the negative effects of ageism were found in over 95% of the ageism studies, that ageism has a insidious and harmful effect on older persons' health. Now, from a more of a mechanistic perspective, also from this review, we identify several things. Contrary to our intuition, because older persons are one of the demographic commonly used, demographic group that commonly use our healthcare system and resources. But at the same time, we also identify the most well-studied link between ageism and health actually takes place in the denial of access to health care. And there are several structural domains which I'd love to talk more about, is thinking about the lack of work opportunities and the exclusion for healthcare trials, for instance. So to give you a few more examples, coming back to thinking about the denied access to healthcare and treatments. In this systematic review, we found plenty of studies actually using population-based data. And this example I wanted to give you is that they were looking at the registry of patients who are hospitalized in the States, over 9,000 actually in this study. And what they found was that healthcare providers were more likely to withhold treatments, and these are life-sustaining treatments from older patients compared to younger patients. And this is after accounting for prognosis as well as patients' own care preferences. In other words, simply because of the age, it doesn't matter of the patient prognosis as well as one's own preference for care. And this also goes to patients who wanted more aggressive care. Physicians were less likely to actually believe that their own preferences when the patients were older in age, in chronological age, compared to younger patients. And when I presented this to different community members, and I often had the experience that many older persons immediately were nodding, and they can tell me 5 or 10 stories where they have experienced similar dynamics when they're interacting with healthcare providers. Another example, for instance, is at the structural domain is really the exclusion from health research in general and clinical trials in particular. Because when you're thinking about the clinical trials, really the goal is to design and develop treatment that can be helpful for older persons, and a lot of these chronological medical specialties actually will most likely be working with older persons. However, we found that in these global trial data, including more than 200 countries, we found that a lot of these trials actually use an arbitrary upper age limit. For instance, in the Parkinson's trial, in some of the dementia, Alzheimer's disease trials, that the older persons are arbitrarily excluded from the healthcare research and in clinical trial participation. And I also wanted to talk a little bit about the policy implications, because we all here care a lot about how to make broader impact. So that really inspire us to do this subsequent research, thinking about the financial cost of ageism, because this is where we think that demonstrating the cost and as well as cost savings associated with ageism may be an important dimension for our policymakers to think about ways to reduce ageism. And we also did a subsequent systematic review, and in collaboration with health economists, we were able to map on 3 dimensions of ageism, as you see on the x-axis, combining age discrimination, negative age stereotypes, and negative self-perceptions of aging. When we actually found out that ageism is quite expensive. accounts for every $1 in $7 spent on the 8 most expensive chronic conditions in our healthcare expenditure in that year. So to give everyone a reference point, this is actually greater than the total amount that the US spent on healthcare costs on morbid obesity for that year. So hopefully that can start some of our narratives and conversations about structural ageism per se. But I also wanted to then bring you back to thinking about elder mistreatment, given that we know ageism impacts health, access to health, and there are health and financial and societal burdens that are associated with ageism. It is plausible that it can impact elder mistreatment as an important social determinant of health. And our work was subsequently examining that association and showing that it is in fact the case. So let me walk you through a series of studies that we did a couple of years ago back, and this is another global study, and in fact, one of the largest cross-national studies on violence against older persons. And in this study, we developed a country-level structural ageism index, and this is based on structural stigma literature. We grouped 2 components that are part of the structural ageism index. One is the discriminatory social policies from 4 domains: economic, social, civil, and political rights. And these are really drawn from data gathered from WHO, UN, global health surveillance databases, as well as World Value Survey. That we were able to gather all these country level indicators of structural ageism. So as I mentioned, one is looking at these discriminatory social policies, so policy that implicitly or explicitly exclude older persons or discriminate against older persons. And the second domain is the societal based norms or cultural norms, because again, ageism is very much of a socially and culturally based belief about aging. So then combining both indicators, we then wanted to see if it predicts violence against older persons at the country level. And we did then find out that that was indeed the case. We found higher countries with higher structural ageism, and this is based on a sample of 56 countries, that higher structural ageism is associated with greater prevalence of violence against older persons. And this is also after accounting for socioeconomic indicators, including GNI per capita and population ratio. So in other words, accounting for countries that have greater proportion of older persons relative to younger persons. So still, that is something that we really wanted to think more deeply about, the impact of structural ageism on the country level that may have a profound impact on older persons' experience of violence in general and mistreatment in particular. So this finding would then beg the question, what is the mechanism that links a structural level determinant to individual behavior? And my subsequent study was trying to address that question and found that one potential psychological pathway would be through individuals' negative age beliefs. So in the subsequent study, we actually had 2 cohorts that we recruited. One is looking at the upper part of the panel. We had the general population, over 1,500 individuals. And the second panel is with 400 family caregivers. So those who self-identify as caregivers, that they're providing care to an older family member. So what we found is that their exposure to structural ageism then really transformed or trickled down to individuals holding more negative age stereotypes that subsequently were associated with either the proclivity or the likelihood to perpetrate elder mistreatment in the general cohort sample. And that pattern was then replicated in the family caregiver cohort in the lower panel, where we found caregivers who held more negative age stereotypes are also more likely to practice neglectful and abusive caregiving behavior toward their family members. And again, this is, we accounted for some of the common risk individual level factors that we know, for instance, stress and burden and socioeconomic indicators. Last but not least, there's also other ways that ageism may relate to elder mistreatment, and it's actually through the implicit form. So, for instance, we know that implicit bias in racism has gained a lot of attention, and in fact, implicit bias also plays a very important role in ageism as we know it. So in this work, we actually examine the most extreme form of implicit ageism. As you see, it's the implicit dehumanization toward older persons. So in other words, denying the humanness of older persons. Based on some of the implicit social cognitive literature, perhaps some of you are familiar with the implicit association test, we actually developed this measure to be able to focus on this bias. And the main idea is, as you see at the computer key, is that making a response will be easier when the closely related items are sharing the same response key. So we would say that one has an implicit humanization bias toward older people if they're faster in associating words when between older people and animals and younger people and humans relative to the reverse. So really using those comparators to capture a lot of the implicit biases, in other words, the beliefs that are operating without our awareness. So then we were using this newly validated tool in a web-based survey of family caregiver sample. And we found that surprisingly, caregivers, actually 1/3 of the caregivers in our example had explicit dehumanization bias toward older persons. And over half of them actually have the implicit dehumanization bias toward older persons. And very much really showing our hypothesis was that older family caregivers were more likely to perpetrate neglectful and abusive caregiving behavior if they had strong endorsement for implicit humanization and controlling for other commonly non-risk factors for elder mistreatment and neglect. So for the remaining of our time, I actually wanted to show you other ways in which social determinant of health may play an important role in abuse and mistreatment against older persons. So I wanted to then bring your attention to thinking about the role of race, ethnicity, and racism. And actually, this is some of my current ongoing work takes place in long-term care setting and in nursing homes specifically. So when we think about nursing home violence, what typically comes to mind are scenarios where staff members, providers abusing residents and mistreating residents, because these are really the stories that typically make headlines and in our news. And we really have zero tolerance for any type of abuse and violence. But today I wanted to show you that the research actually suggests the most prevalent and persistent form of violence in nursing homes are the ones that take place between residents. So this is what we call resident-to-resident aggression. And this really refers to the negative and aggressive interaction ranging from physical to sexual to verbal between residents that were likely to cause high physical and psychological distress in the recipient. And based on some of the seminal studies that were conducted in this field, we know that around 20% or every 1 in 5 resident in long-term care experience an incident of resident-resident aggression in any given month. It is not always recognized, and sometimes it is seen as normal behavior that is just part of the fabrics of everyday life in long-term care setting. And my area of interest, as you know, is really surrounding this larger structural and social determinants. And I'm particularly interested to think about the role of race ethnicity in this very complicated phenomenon to hopefully address and potentially have some solutions for interventions. So just to show you very quickly, race or racism in this scenario is really some of the implicit and explicit factors that may take place in resident-to-resident aggression, but that has not been explored or studied before. So let me walk you through some examples that race ethnicity may play a role. thinking about the structural level, we do know that our long-term care population, just as our community dwelling population that you all interact with on a day-to-day basis, they're increasingly racially and ethnically diverse. And in long-term care setting, there are also most likely living in congested and congregated care settings. We do know from research at the interpersonal relationship diets, a lot of times that race does play a role in triggering some of these conflicts as well as aggression between, say, resident to staff member, but it has never been studied between residents. And one may argue an important barrier in such is really the beliefs about ageism. Is that why should we care? Why should we care about older persons since institutionalized setting is not something that we prioritize or care deeply about compared to other social institutions. At the individual level, of course, we do know that a lot of our older persons grew up a more segregated way. They probably have no prior interactions with residents from other racial ethnic backgrounds. And most of our residents in nursing homes may very likely have cognitive impairment. So their disinhibited behaviors may prompt them to say things or do things without realizing this impact. So all of that is to say that we do think a better understanding of race, ethnicity, and resident-to-resident aggression could really help our ability to better address it and prevent it. So we then started to explore this line of work in some of the more explicit way. So that is exploring the explicit racial and ethnic conflicts. And I had the good fortune of being able to access some of the, perhaps one of the best and largest data set that capture resident-to-resident aggression in a very comprehensive manner. This was data set that was from 10 randomly selected nursing homes, what consisted with over 2,000 residents that are randomly selected and all in the state of New York. And this data set was unique because each of the incident of resident-to-resident aggression came with very detailed report. It's almost like reading a forensic report because it tells you very specifically about the dynamics and the triggers and the consequences. And these are really merged from 6 different sources. So not just the residents themselves, but also staff members and medical charts, etc. So for the interest of time, I'll go straight to show you what we have found so far. So first off, perhaps not surprisingly, we did find that minoritized residents were more likely to experience racial ethnic conflicts rather relative to other forms of resident-to-resident aggression. And at the facility level, at the nursing home level, we did find that nursing homes with greater racial ethnic diversity, as you see here on the right-hand side of the green bars, they were more likely to report frequent racial ethnic conflicts compared to facilities with less diversity. So in other words, it's really distilling down to the idea that diversity does not equate inclusion. And there are a lot of other facility level dynamics that we really wanted to look closer into in our subsequent research. But perhaps I think what was at least most concerning to us was that the fact that the majority of these racial ethnic conflicts really took place repeatedly. So again and again, between the same pair of residents. So over about 56% of these incidents take place between the same pair of residents. So this really suggests that these conflicts are very likely normalized. They probably received limited or perhaps no institutional attention at all. Then we also wanted to contextualize some of these explicit racial ethnic conflicts. What does it mean? What does it look like? How does it manifest in residents' day-to-day lives? And we actually find 5 very distinct patterns of racial ethnic conflicts. So there are really the more explicit physical violence that are racially and ethnically motivated, that has obviously the risk of causing immediate harm. But we also see some of the more microaggression type of resident to resident aggression that may be more assiduous, but still equally damaging to the well-being of residents as well as the residents around them. So it's really at the community that we are concerned about. So again, this is ongoing research, so I just wanted to show you that we're continuing to explore the role of racism, both at the explicit level and implicit level in long-term care setting. We're really just scratching the surface, and I think there are just, parallel dynamics that we can talk about perhaps later in our discussion, how this manifests differently in some of the community based mistreatment and neglect issues that we have all experienced from our clients as well as our study participants. But all of which is really to say, thinking about racism that perpetrate on the individual, dyadic, and facility level, that together I think that could help us to better develop a toolkit, which is really the angle of this line of research, to help our frontline workers in nursing homes to be better equipped to understand the role of race ethnicity related resident to resident aggression, and that can help address some of these inequities that are taking place in long-term care setting. So that really brings to my perhaps last point in this presentation, is really the path forward. How do we engage and integrate the role of social determinants in designing elder mistreatment, neglect, exploitation type of, or in this context, in the interventions that can help individuals who experience abuse and neglect? So first, I wanted to actually give you a preview of the things that we have been developing in quality of care in the nursing home space. So again, this chart that you've seen before is there are many domains to thinking about social determinants of health. And one thing based on what I described, I'm really most interested in thinking about ageism and racism. So that brings in the role of thinking about healthcare systems and the micro level. Are there ways to help our providers to increase their cultural sensitivity training so that they can provide better care to our residents and vulnerable older persons? So I wanted to quickly talk to you about this pilot program that we have been developing, and this is in partnership with University of Southern California. That's a part of the Geriatric Workforce Enhancement Program, GWEP, that's funded by the Health Resources and Services Administration. We are currently developing and also piloting this CNA toolkit. In other words, this is really the cultural sensitivity training that are specifically tailored toward the use of certified nursing assistants in nursing homes. So in other words, we do know there are plenty of cultural sensitivity trainings for nurses, registered nurses, and other healthcare providers, but we couldn't find anything that's tailored towards CNAs. And we do know aides are really the unsung heroes before pandemic, during, and after. And there are really no good toolkit that can help them better connect and provide cross-cultural care and communication to residents, especially given that a lot of their work dynamics are really to provide the most intimate ADL, IADL help to nursing home residents. So this toolkit is supposed to be something that very practical, because when they walk out from this one hour training, we want them to be able to think about a few strategies that they can use in stressful caregiving situations. And this is part of the larger initiative to help improve age-friendly nursing home. So CARE here stands for curiosity, awareness, rooting out bias, and empathy. And for each of the mini module within the larger module, we have practices and for CNAs to try and within and after the training. So again, just a few things, since this is still ongoing, and we're piloting a few nursing homes in California right now. But this is just one example where we can really address key social determinant of health, which is provider cultural sensitivity. And we have pretty good preliminary feasibility and acceptability among the workforce workers as well as our engaged partners. So for instance, all of the participants and CNAs, they have recognized the importance of learning cross-cultural care, and that they feel confident or very confident in providing cross-cultural care after the training. So again, this is one example in which we can integrate some of the ongoing training to specifically tailor toward the needs of workforce. And that may be something, for instance, for our adult protective services, for a lot of other workforces that work intimately and so closely with older persons on quality of care issues, or ways to prevent or intervene on elder mistreatment, neglect, and exploitation. So this is going to be my last slide, because I was sharing earlier that I was hoping that this could be more of a dialogue, because there's a lot of work that I think the researchers and practitioners can really work closely together in thinking about the implications for practice. So one of the immediate need is really thinking about cultural sensitivity training in elder mistreatment prevention and intervention. I know this perhaps is a topic that many of you are already experts in or interested in learning more. And I hope we can have a little bit of time talking about where the needs are and how can we work collaboratively in toward this direction. Some of the things I can think about working with our collaborators and partners on the ground is obviously thinking about increasing community awareness. Why it's important to think about cultural sensitivity in terms of age itself is culturally based bias. So it's not just about racial, ethnic, and cultural, but it's really the thinking about age biases to be a part of this broader phenomenon as well. Reducing biases and prejudices. And this is based on our ongoing work with the nursing home certified nursing assistants, is that we had really received very positive feedback, that many of them shared with us that, yes, they have perhaps done the implicit association test on the internet, or they have gone through 5 minutes talking about why it's important to have a culturally inclusive nursing home environment, but they're not real practices. And when we're a corner into that 5 minute or 3 minutes to provide care, a lot of times it's really hard to decompress and use a strategy that can be practical and that could really enhance quality of care. So it's really some of the practices and strategies can be very useful for day-to-day use for our healthcare workers in different healthcare institutions as well as healthcare system. And something else that lesson learned that we found can be very useful is actually to engage older persons and care partners with lived-in experience from diverse backgrounds. Because again, this is a project. This is really the intervention that we're hoping to integrate some of these restorative justice principles, that they are also key partners in developing intervention that can ultimately benefit older persons, their loved ones, care partners in the community. So that may be another takeaway lesson that we have learned so far. But last but not least, I hope that I'm leaving enough time, because I think, again, it is really the research and practice collaboration that can help inform moving the field forward, especially distilling some of the social determinants and the influences that I spoke briefly about. So I believe that will be the last of my question posed to you, is that what else do we need? What else can we do together to really move the paradigm forward and thinking about prevention and intervention space? And I know there are great programs that are being piloted and practiced, and I'm really eager to learn from your experience as well. So I'm going to leave you with that knowledge. Again, this is research is about team science, my amazing mentors and collaborators, and our research participants who really share their wisdom with us so graciously. So thank you so much. And I am eager to learn from your experience. So I hope we will have enough time for discussion. So thank you again.
Yeah, so Iggy, I see that Brandy wants to know if we can get a copy of the PowerPoint and the video. So we normally post the recording on the website, and if it's okay with you, if you want to share the PowerPoint, we will post it normally the recording and the PowerPoint as well, depending if the presenter is okay with that. And And there was another question from Anne McQueen. Not sure. Do you see that in the chat? Or let me. And if you would like to unmute yourself, you're more than welcome to, or we can answer the question from the chat.
Sure. Thank you for a great presentation. I was wondering if you've seen differences between residents and resident-to-resident altercations between people who are experiencing cognitive impairment versus those not experiencing cognitive impairment. And I know that's hard because there are so many levels of varying cognitive impairment out there, but that was my question. Thank you.
Yeah, absolutely. Thank you, Anne, for the excellent question. So I will speak more specifically in the resident-to-resident aggression research, is that cognitive impairment is indeed a risk factor, but there are, as you mentioned, there are multiple levels of how, in terms of the disease prognosis and diagnosis, et cetera. And because the data set that we worked with included over 2,000 residents, and that has very specific detailed information regarding their self-reported cognitive impairment with all the tests that we've done, we were able to actually categorize their level of cognitive impairment. And what we found is that the most pronounced level of cognitive impairment that is a risk factor for getting involved in resident-to-resident aggression is actually not those with the most severe form of cognitive impairment. In other words, those are really the ones who are most vulnerable, they're a bit more bedridden. And if you think about aggression in this context, it's actually an aggressive form of social interaction that does require cognitive and social reservoir for you to get into an aggressive episode with other residents. So in other words, we found the residents most likely to be involved in a incident are those with a moderate level of cognitive impairment. In other words, they have the capacity in a way to get into harm's way, that a lot of the wandering behavior, a lot of the physical and verbal interaction with other residents. So I think that's something we're continuing to look into. And to another side note to that is then we also looked at, some of my mentors are really the leading experts in this work, is looking at the memory care, special care unit, that they did find more incidents of resident-to-resident aggression that take place in memory care. So then that begs the question, is that we do think special care units or memory care units, some of the terms are used differently in different localities, should be the place or the environment where our loved ones with cognitive impairment may receive the better care for the highly specialized care in dementia. But in the context of resident-to-resident aggression, it's not necessarily the case. However, another I think caveat I want to throw out there is that it's highly correlated with the resident to staff ratio. So if you have a home space that has less staff members on board, there are likely to experience more aggressive episodes, and that very much go along with the rest of the quality of care literature we know in the long-term care space. So it's a long answer to your short question, but again, we're really starting to scratch the surface and also trying to look more deeply into how minoritized older persons with cognitive impairment and without may experience resident-to-resident aggression similarly or differently. Other questions?
Yeah.
Yes.
Kenneth, if you want to unmute yourself, or we can.
Sure. No, can you hear me?
Yes.
Wonderful. Thank you. No, it's fascinating work. Many staff in long-term care facilities are themselves from racial ethnic backgrounds, as are many home health aides. And I'm wondering if I could imagine this could help, but maybe even complicate efforts to promote culturally sensitive caregiving. So I'm wondering if you've been able to look at this at all in the data sets that you've worked with, or if not, or how would you hope to do so?
Yes, absolutely. Thank you, Kenny, for that really important question. So I am continuing to collect data, and right now I'm actually collecting qualitative data to better address these questions. So even so, to give you an example that just comes to mind is that I am trying to understand the perspectives from stakeholders, including CNAs, in terms of their experience and perception of residents who get into racial ethnic conflicts with one another. So that typically is the first question that I ask in focus groups or individual interviews with CNAs. And the first response that they typically give me is that, are you more concerned about the racial ethnic conflicts between residents, or are you interested in learning the resident initiated racial biases or aggression towards staff members? So that is definitely, I echo your concern. That is definitely still, I think, one of the top priorities and concern areas for many of our racialized and minoritized staff members, and especially CNAs in this case. So the final product that we're hoping to develop with the input as really the core partners for this project are CNAs themselves from diverse racial, ethnic, cultural backgrounds. And perhaps New York City, where I work, is also a good place to do that, because we really see that high level of diversity. So what we're hoping to do is actually to integrate some of the ways in which that they may be better to understand and improve some of the anti-racism measures at the structural level. So in other words, we have not really embarked on this work yet, but can there be an anti-violence or anti-racism campaign in nursing home as a public health campaign? That would be at the structural level. But again, it's involving all the buy-ins for different, administrators, as well as directors of nursing, administration, and medical directors on board. So that may be one structural way of doing that. But the toolkit that we're developing right now will really be tailored toward thinking about the cross-cultural communication. So the example that I was giving you is that we actually talk to CNAs right now to think about, be aware of their own biases as one way to understand the broader dynamics. But the other component is really, how do you cope with these racial biases that they receive at work as a consequence of occupational hazard? Really, that's the word that they're describing, that is part of the job. So there are many ways that I think we can do this, and do this well, with the input of our frontline workers. So hopefully this is just the beginning as we're wrapping up our qualitative interviews. So hopefully we'll be invited back to give another talk when we come to that point. So
wonderful. Thank you.
Thank you, Kenny.
There was another question from Brandy.
Yeah, I was wondering, is the care training available now for any nursing home in the US, or is it just still in like a pilot project? And if and when it's available, is there going to be a cost to it? How are we going to get it into the nursing homes? There are so many.
Sure. Yeah, no, thank you, Brandy, for your interest. So it is available right now. We are piloting it. This is, again, the project is led by our partners in University of Southern California as the broader age-friendly nursing home initiative. It actually has 4 modules. And the part that I'm taking the lead on is specifically in cultural sensitivity. Right now, because again, this is funded by GWEP, and they are funding us to now look at the development and piloting the content to tailor it for a few other nursing homes, specifically in California. But we're very interested to actually think about ways to work with other partners across the country. So I have my last slide here still, because I wanted to talk about this. If you're interested in thinking about ways that we can collaborate and that can benefit you or your staff members, please write me an email. We're very happy to share these materials and think about ways that we can collect some of the data as well, so we can continue to fine-tune and tailor this toolkit for our frontline workers in nursing homes. So please feel free to reach out, Brandy, as well as other listeners on the line.
Great. And that's amazing because I think it will help. I'd be interested to know too, based on Kenneth's question and your statements to him. Um, I wonder how many of our CNAs are experiencing discrimination and racism in the nursing homes where we're seeing high rates of resident on resident aggression. I think
Yes.
you're going to find a correlation. I don't know if that's part of your project or not, but I think there will be a correlation there.
Yes, absolutely. So our concern actually is we are hypothesizing on the correlation. This has actually not been studied so well in the past, and that is
Yeah.
part of where our team wanted to come in and do a better job. But I think one of the concern for this downstream consequences is it also will create staff's CNA's hesitation to go into the room to help the staff or to help the resident who had exhibited some of these aggressive behavior, and that could very much result in the downstream neglect, care neglect, and that would really damage residents' own health and well-being. And that association, I think, has been suggested in a few other projects already, but we wanted to especially highlight the role of minoritized staff members in really empowering them and supporting them through this. In other words, the final goal is still with that empowerment that we can also be sure to better support the care of residents so they can get better support, even with some of the aggressive behaviors or racially initiated behaviors. So the final sort of statement I wanted to put out there is that all of these forms are very much interrelated. So we are actually studying resident to resident aggression. We are studying resident aggression, resident initiated aggression towards staff members, as well as the other form that are commonly really we heard sort of in the media, the staff initiated residents. And that all together, if you think about other parallel form of public health campaign, it's basically at schools that would not be tolerated. There will always be this anti-bullying program, but in nursing homes or other long-term care, we've really not done enough. And again, that brings back to the understanding and beliefs about ageism. So that is really the ecosystem in long-term care that we wanted to do more. And I really welcome your collaboration expertise in this as well.
It's really fascinating. Thank you.
Thank you, Brandy, and please shoot me an email. I really love
I
that.
will for sure.
Thanks.
All right. There's one, they don't have a name on the Q&A box. Do you see that one? Right? I don't know if you have any comments to add on that.
Okay. Would you like to read it, Esther?
Oh, yeah, sure. Okay, so it says, great talk, thank you. In addition to focusing on caregivers and thinking of faculty level implications, there's a lot of evidence in criminology, sociology that collective efficiency matters to prevent crime in communities. I wonder if finding ways to encourage nursing home residents to work together, identify common goals, build trust with their peers, etc., may also be another fruitful intervention / strategy to consider.
Yes, no, that is such a great comment. So thank you for that comment. And we are actually, this came up very organically from a conversation with a few residents because they were involved in the resident care council. So we do believe at the core of our work that this needs to be an intervention that come from the residents that can be tailored toward their own needs with their own lived experiences. And I think that very much would echo to most of the elder mistreatment prevention projects that are ongoing to really prioritize their own voices and their own experiences. So we are still, this is ongoing work, but we are very eager and interested in working with some of our local nursing homes to talk about this in the local resident care council. And some of the care councils also are open to family members, where they have given really great insights in terms of integrating this into their broader care protocol that should be consistently keeping all the family members as well as residents in the loop. Other ways to encourage nursing home residents to work together. I think this is it's really like working with very diverse social groups. Sometimes when you go into a nursing home, you do find that depending on how the social activities are designed, sometimes folks know each other very well for a very long time. And those are actually, we have the luxury of starting with some of these more closely knit circles of nursing home residents to learn from their experience. And that, again, we are running actually a few focus groups next week to gather really wisdom from their experiences to see how we can then spearhead this work with their input. So I do not think there are any toolkits that exist at this time, but that will be a really an amazing deliverable and product that we will be happy to help develop. And I, again, welcome your participation and your feedback if this is something that may interest you as well.
Okay, perfect. Well, thank you again, everyone. And thank you so much, Iggy, for sharing. I really appreciate it. It was an amazing presentation. Just a friendly reminder that the presentation has been recorded and will be uploaded on our website, maybe this week or early next week. Again, thank you all so much for attending today's webinar. We hope you have a great day.
Thank
Bye.
you so much for having me. Take care.
Bye.